Question, not a comment. That's the problem in this patient. Has always been the anal fissure with the hypertone. Always, also at the very beginning, strangulating the bites and provoking the complication of the necrosis, and of course, 0.1% of the fissure. In 0.1% of the fissure, you may have an abscess, and this was the case.
Right, exactly.
It's the anal hypertone.
I do think he has a hypertonic anal tone, but it was actually, the pain started actually 3 days. So the fissure was acute at that time, that's definitely for sure. But actually what we do is we gave the patient GTNs, and usually the patient, he actually got it. He got the GTN, but actually he did not respond very well to it. I also think this patient has functional constipation, because he has very straightforward history of functional constipation. He goes to the toilet, sits for a long time. History of digitation is there, quite as like the previous patient which Sir already showed. We will do MR defigogram for this patient, and maybe that has to be treated as well. He definitely told me that he still has the constipation, and he would like it to be treated as well right now. So we will, in the future, we will talk about the constipation, what the final outcome is.
What was the status of continence after surgery?
Sir, initially after the surgery, he definitely complained about some degree of incontinence. But at this moment, I did not ask him about the continence, because I know if I ask him what is your continence level, he's definitely going to complain about that. But it's not a severe problem. He's just happy that it's not there. The pain is not there, the bleeding is not there, the swelling is not there.
LIS was not done.
In this patient? No, sir. In this patient at that time I did not do the LIS. I am still scared of that. Well, there will be a recurrent fistula as well now. Recurrent fissure. But I didn't have the courage to do a LIS at that moment. I was scared that it might have aggravate the incontinence.
What is your expectation regarding stenosis, anal stenosis?
Sir, after the surgery, yes, huge amount of anal mucosa was lost. Actually, perianal mucosa was lost, but fortunately, this gentleman, the anoderm was not lost in this patient. So actually, the stricture actually happens if you lose the anoderm. So the anoderm was preserved in this case.
Did you give any advice to prevent stricture?
At that time, I did the examination. I did not find any strictures, sir, but certainly that is in my mind, and I told him for follow-up up to 6 months.
Do you think that there is any role for self-dilatation?
In this patient, at this moment, I don't think so, because there is no sign of stricture at this moment, sir.
Last question. Sorry for this. Did you perform an endoanal ultrasound?
No, sir.
OR
No.
Before the procedure?
No, I did not.
And which kind of fistula abscess this?
This is a low variety fistula, sir. A low variety transsphincteric fistula.
So that's the problem.
Yeah.
But okay. Pelvic floor rehabilitation?
Rehabilitation? No, I have followed up the patient quite closely. The only complaint the patient has is he still has that constipation, the functional constipation. He goes to the toilet, sits for a long time. That is the only thing. Medications are not working for this gentleman. But rehabilitation, certainly we can go for the Kegel exercise, and the other rehabilitation should be, I will perform, maybe biofeedback would be a good idea for this gentleman. We are thinking about doing the MR defigogram, and whether it's mainly a functional problem or a structural problem that we want to deduce first. Maybe biofeedback would be a good idea for this gentleman.
Probably this scar will help the patients to avoid incontinence.
There is a possibility. Definitely there is a possibility for that. And so far he did not talk about it, but let's see what happens. That is what
is flatus incontinence. It should be
flatus. I think he will have flatus incontinence.
Deformity.
I think what Dalia was keyhole deformity.
Keyhole deformity. Interestingly, this gentleman, very interestingly, there was not a keyhole deformity, but the deformity was slightly lateral. Not at the 6 o'clock. It was very interestingly at 7 o'clock, I think. But it wasn't a keyhole, not exactly. Not exactly.
In your picture, actually, at the end, it looked like a stenosis because that thing was very thin. It looked as if it was a stenosis.
There is some degree of stenosis. I won't disagree with that. There is some degree of incontinence as well, sir. These are, but at the end of the day, patient is quite happy to be relieved of those problems.
I work in a high-end private practice, so I think the patient slap me if I try to do a proctoscope case. But I know, but let's move back. So, slightly, for our patients, I can quickly get them down to our endoscopy suite, give them sedation. I use methadone propofol, and they're quite relaxed to do the proctoscope for our patients.
So the proctoscopy in those type of questions, when you acute an issue,
well, what it is,
because it's a violence to do proctoscopy. Is a violence in the outpatient clinic.
Yeah, so
it's absolutely not correct to do that if there is anal hyperton, because they feel uncomfortable. So what you do is an evaluation under anesthesia if you would like to do something for the patients. Otherwise, with acute anal fissure, it's absolutely not recommended to do the proctoscopy in the outpatient clinic. Absolutely no. But most in Italy. But most of the times, lidocaine cannot act on hypertonic anal fissure.
Does that?
Yeah, I don't know. Especially if you have female patients, they do not feel comfortable with the proctoscope with anal fissure. They will feel pain, and it's such type of, I don't know. For me, it's not recommended as.
So apply little jelly at the inner watch, then go a little inside, apply a little more, then wait for some time, go a little more. So it takes time, but you're able to do it.
all right, thank you. You had
The good examination under anesthesia seems to be the better options.
I know, but to take the patient with anesthesia, a lot of cost is involved in that.
If there is the possibility to do that, of course, but it's the best choice.
Thank you so much.
Thank you, sir. Thank you.